മനു ഇത് എൻ്റെ മൊത്തം അപ്പോൾ അതിൽ സൗണ്ട് ഇട്ട് ഓഫാക്കിയിട്ടാണ് ഇതിങ്ങനെ വരാനും ചോദിക്കുന്നത് ഇതിലെന്താ വരാത്താണ് വീഡിയോ അനു ഇപ്പോഴും ഞാൻ നടക്ക് വന്നില്ലല്ലോ. Hi, good morning everyone. Hello, am I audible?
Yes, sir.
One of you can unmute your mic and tell me whether I am audible.
Hello, sir.
Hello.
Hello, sir.
Am I audible?
Yes, sir.
Clear?
Yes, sir.
Okay. Okay. Good morning. Today, actually, I think this is the first class in orthopedics, isn't it?
Yes, sir.
So I will just go through the housekeeping rules. Today I will be discussing, coming 40-45 minutes, I will be discussing about dislocation of the shoulder. And at the same time, I will also be covering one small topic, proximal humerus fractures. Actually, the first topic is very, very important for you, the dislocations of shoulder, because you see these patients often in casualty. Even in playgrounds, when you are playing, if you're playing football, you fall down, sometimes you get a shoulder dislocation. Sometimes your colleague, your friend gets a shoulder dislocation, and if you know how to reduce it in the field itself, you are going to be very well appreciated. Then the second topic that I have for today is as a short topic on proximal humerus fractures. But this proximal humerus fracture is not very important for the undergraduate discussion. But anyway, we will go through this and we will go through what is important for the undergraduate. Okay. So the general housekeeping rules are, I understand there are 98 participants coming to the Zoom, and maybe some people will be watching live through the YouTube link. So as our class leader, Abdullah, Abdullah has informed me that there should be an attendance. There should be an attendance. I request who are watching through the YouTube to just give a hi in their via their Gmail IDs. So that is a general housekeeping rule, and anybody who has got a doubt can raise their hands or can use the chat box to raise the question, preferably through the chat box, so that the lecture will go on smoothly. And if there is any problem in connectivity or audio issues, that is you can use the chat box. So shall I start now?
Yes, sir.
Okay. So I will be sharing my screen. So, so my first topic today will be about, I'll be discussing about shoulder dislocation. For those who don't know me, many of you, almost all of you may not be knowing me because I got recently transferred from Trivandrum to Alleppey. In January, I came in January after completing my 15 years of service in Trivandrum. So, so wonderful to have you here. Many of you, personally, I do not like this online classes, but there's no other way out. So when you have a physical class, you know what your students are understanding in front of you. You can change your way of presentation. You can change your way of teaching. You can ask them questions. So all this kind of physical interactivity is actually missing in this COVID times. So anyway, we should not take that as a deterrent. We have now so many platforms for the online discussion, and online learning tool is here to stay. And many of your courses are also going to be online from now on. So we will discuss about shoulder dislocation. Now, the way I speak, I take class is I don't go for a didactic lecture. I will give you the questions that are going to be asked in exam and how to prepare for them. First, you can, because there are so many reading resources are available in textbooks, in internet and everything. So there is no point in going for a didactic lecture. But what I will do is I will be giving you the questions that are going to be asked for university exam and how to answer them correctly. So there are few questions that are this shoulder dislocation is a high yield topic that you have to understand. So there are certain questions that will be oft repeated for a structured essay, the short answer questions, and even the short note. So clinical features of shoulder dislocation is often asked question. Then sometimes the examiners are fond of asking 4 clinical tests of shoulder dislocation. Techniques of reduction of shoulder dislocation is often asked, particularly the Cohort method. Then what is a Bangard's lesion as a short note, and sometimes a clinical scenario can be kept with regard to shoulder dislocation to be asked as a structured essay. So when you come to shoulder dislocation, you know that shoulder is one of the most unstable joints in the body. Why it is unstable? It is unstable because though it is called as a ball and socket joint, the ball is really the ball is there, but the socket is really flat. The socket is the glenoid. It's really flat. If you take the analogy of a hip joint, you know that hip joint is one of the most stable joints in the body. Why is it so stable? Because the cup is so developed like a mirror image of your ball. So the head of the femur is articulating within the cup, which is almost 2/3 of a sphere. So inherently there is an anatomical stability given to the hip joint. But in the case of a shoulder joint, what is the problem? The shoulder joint per se is articulated. The humeral head, which is a spherical structure, is articulating with a relatively flat structure of the glenoid. Why is it so? Because you need the upper limb to have maximum mobility. So in shoulder, mobility is compromised, stability is compromised for mobility. That is the reason why shoulder joint happens to be the most common dislocating joint. Okay, when somebody tells about dislocation, you should have a clear idea of what is dislocation. So what is the definition of dislocation? See, I am showing you an X-ray here. I am showing you an X-ray here. You can see that this is the glenoid part. This is the humeral head part. Okay, so the humeral head is totally lying outside the glenoid. You know, when somebody tells you that there is a dislocation, you have certain clinical idea in your mind. But by definition, what is a dislocation? Dislocation is a complete loss of articular congruity between the members that form a joint. So that is dislocation. That is when there is a complete loss of articular congruity between the members of a joint. Subluxation means partial loss of articular congruity between the members of a joint. Okay. Now, depending upon the direction of dislocation, shoulder dislocations can be different types. Okay, you know that anterior dislocation, it is the most common type. because 95% out of 100 patients you take coming to casualty with the shoulder dislocation, 95% of patients are going to have anterior dislocation. 3% of patients or maybe 4% of patients will have what is known as a posterior dislocation. So then there is a small percentage of patients which have something known as an inferior dislocation. Because in my experience, I have seen only 3 cases of inferior dislocation. So you know how much it is going to be rare. Then there are some very rare form of dislocations also. So 95% of dislocations are going to be anterior. And depending upon where the head is going to rest, it can be a subcoracoid, because it is going to under the coracoid. It can be subglenoid, it can be subclavicular, or sometimes it can be intrathoracic. It's very rare. I have not seen one intrathoracic, but it is there in the book. Okay, so anterior can be subcoracoid, subglenoid, subclavicular, and intrathoracic. And I told you posterior is a very rare, but the question here is, in posterior dislocation, there are 2 things that are important. Posterior dislocation usually occurs in patients who are having seizures. You know that when there is an epileptic attack or a fits attack, the upper limbs will be going in a frenzied motion, and these patients can undergo posterior dislocation. Second thing, when you get an electric shock, and you fall down, so that is one situation when you get a posterior dislocation. Why I am telling this history is very important, because posterior dislocation it is difficult to identify in an X-ray unless you are specifically looking at it. But here the history gives you the clue. If the patient is coming with the pain in the upper limb, difficulty in moving the upper limb following a seizure attack, the bell should ring in your mind. The bell should ring in your mind that there is a possibility of a posterior dislocation, and you should specifically look in the X-ray. Suppose the patient is coming after electrocution, you should specifically look in the X-ray for a posterior dislocation, because posterior dislocation is often missed in the casualty, and the patient will end up having a functionless upper limb. Then, as I told you, there are other dislocations like inferior dislocation, superior dislocation, inferior dislocation. These are very rare. I told you, I have seen only 3 cases of inferior dislocation in my 17-18 years. Okay, so the classification I have covered. So then we will come to the then we know we have to look at, there is something known as a habitual dislocation. Habitual dislocation means, as a habit, a person is able to dislocate, and most probably they will be able to relocate themselves also. This is usually bilateral, and it is usually painless. You can see, you will have seen certain circus clowns. They are able, because they have certain congenital conditions, like genetic disorders, which causes generalized ligamentous laxity, and they are able to dislocate and relocate their shoulder. So that is known as a habitual dislocation. It has become a habit for them. Then the term in inferior dislocation, see, there is a term that is luxatio erecta. So that is a term that is used for defining an inferior dislocation, luxatio erecta. Now, usually, like this question, what are the clinical features? What are the clinical features of a shoulder dislocation? Okay, how the patient comes to the casualty. Now, patient comes with usually he comes after with a history of fall. Sometimes he comes with another history. He was lying in the bed, sleeping in the bed, and suddenly he had a popping sound in the shoulder, and after that he is having excruciating pain in the shoulder and is unable to use or move the upper limb. And how he comes to the casualty is what is shown in this figure here. See, he will be holding the arm slightly abducted, that is the attitude of the limb. He will be supporting the arm with the other side, with the other hand, and he will be coming to the casualty. So that is the shoulder is slightly abducted and the elbow is slightly flexed. Is kept flexed to relieve the pain. That is how the patient usually comes to the casualty. So now you are suspecting the shoulder dislocation. So this is the clinical picture. Just give an attention to this clinical picture. I have taken a photograph of a patient with a shoulder dislocation. Now look at your own shoulder. Now your own shoulder has got a deltoid bulge. See, you even in the thinnest person, you will have See, there will be a shoulder. The deltoid prominence will be there on the shoulder. This will be absent. Why is that deltoid is prominent? Because the humeral head is lying underneath the deltoid, and that is giving the prominence in the shoulder. When the shoulder is dislocated, the humerus head will be falling. Humerus head will be somewhere outside the glenoid. So the deltoid appears to be flat. This sign is known as deltoid flattening, or it is also known as squaring up of the shoulder. See, it is almost like the rounding of the shoulder is lost, and you get a squaring of the shoulder. And sometimes in thin persons, you will be able to see a visible bulge of the humeral head here in the subcoracoid area. Okay, so that is the inspection. That's a loss of the humeral, the deltoid contour, squaring of the shoulder joint, and sometimes an anterior prominence. If it is an anterior dislocation, it's an anterior prominence in the subcoracoid area. Okay, then see one more photograph. See, look at the other side. The glenoid the deltoid prominence here, and there is a squaring of the deltoid. Okay. So there is loss. So for the clinical features are loss of contour of the shoulder. Now there is one more test. Then now we can do certain tests. Now you ask the patient to touch the opposite shoulder. Normally we will be able to touch the opposite shoulder. Okay, but in a patient with a shoulder dislocation, you will not be able to touch the opposite shoulder. This is known as the Dugas test. Dugas test. Okay. Now there is another test which is known as the Callaway test. Callaway's test is, now you take a measuring tape and measure the vertical circumference of the axilla. You have a certain value. Now you do it on the opposite side, on the affected side. What happens is because the humeral head is lying somewhere outside the shoulder, the vertical circumference of the shoulder is more in the side in which it is dislocated. So that is known as the Callaway's test. Then the fourth test that you have is the Hamilton ruler test. Hamilton ruler test. Now assume that this is a ruler. Now if you keep over your deltoid and vertically over the deltoid, it will not be touching your lateral epicondyle. Okay, in a normal shoulder. Why? Because of the deltoid prominence. But in a patient with a dislocated shoulder, if you keep a straight ruler on the tip of the acromion, vertically down, it will be touching the lateral epicondyle because the ruler is not pushed away by the deltoid. So these are the clinical tests: squaring of the shoulder, Dugas test, Callaway's test, and ruler test. And so these are the special tests that you have for diagnosing shoulder dislocation. Then there is one more thing. So this is an X-ray. This is a radiograph. And what are the one more clinical finding? I will come in a minute or two. This is a X-ray. See, this is a normal X-ray of a shoulder. Normal X-ray of a shoulder. Now, what we will look at, what are the radiological findings of the shoulder dislocation. In normal X-ray, what are the things that you see? This is the glenoid. You can see that the humeral head is here, and you can see there is a slight overlap of the humeral head with the glenoid. And if you draw a line along the lateral border of the spine, the scapula, like this it is coming underneath the glenoid and to the medial border of the humerus. I am repeating, from the lateral border of the scapula down to the glenoid and along the medial border of the humeral head, humerus. It is like a continuous arc. It is like a continuous arc. So that is known as the Shenden's line of the shoulder. You would have heard about Shenden's line of the hip. Everybody would have heard of the Shenden's line of the hip, but there is also one more line in the shoulder, Shenden's line or Shenden's arc in the shoulder. In a dislocated shoulder, what happens is this: there is the Shenden's arc is broken, and the humeral head will be lying usually subcoracoid. See, this is the coracoid process, and the glenoid is empty. That is known as an empty glenoid. Empty glenoid. So these are the radiography. So you can take a simple AP radiograph of the shoulder, and that will confirm your diagnosis. Okay. So another X-ray here. Another X-ray. They see the glenoid is empty. The Shenden's line is broken. The humeral head is lying in the subcoracoid area. This X-ray on the right side is known as a lateral view. So suppose you want to know whether this is an anterior dislocation or a posterior dislocation, from a frontal view it may be difficult. So you can take a lateral view and see that the humeral head is lying towards the coracoid. That means it is anterior. If it is lying here, it is posterior. Okay. Then one more thing, when you get a patient with shoulder dislocation, you have to look at two important things. One is the distal pulse, whether the because the humeral head is lying somewhere in the axilla where there is an important artery, where there is an axillary artery, it is the third part of the subclavian artery, and this part of the artery can be rarely injured. So distal pulsation is very important. Palpation of the distal pulsation is very important. And another thing is to look at the sensation in the deltoid area. This is known as the regiment's badge design. Regiments, I think I have a picture coming up in few seconds. Regiment's badge area, and you have to look at the sensation in this area. It is where the badge of the military people come. That area is supplied by the axillary nerve. So axillary nerve is most commonly injured in a shoulder dislocation. You can have injury to the brachial plexus as well. These are very, very important, because even if you reduce a shoulder, if these nerves are not working, if the axillary nerve, the brachial plexus is not working, patient is not going to have a good recovery, and the patient might even sue you because we have not noticed it's a neurovascular injury. So that portion is very, very important. So I have completed the clinical features now. I have taken you through the clinical signs, and now I will go to the management. So far, any doubts? Shall I go ahead?
Yes, sir.
Okay. See, when a patient with a shoulder dislocation comes, he comes with howling with pain. Howling with pain. This is one of the most painful conditions that you can have. And the beauty of this is that once you reduce the shoulder, once you put back the humeral head into the glenoid, the relief of the patient is so immense that he will thank you for what you have done. And dislocation, for that matter, every dislocation happens to be an emergency because of two important things. One thing is, if you keep the joint in that position for a long time, it is almost difficult to reduce. The result matters. Second thing, there can be compression on the vital structures like the nerves, the vessels, and can result in a catastrophic injury to these structures. So all dislocations are important. To come to shoulder dislocation per se, the shoulder dislocation is if you keep it for more time outside, there is a chance for avascular necrosis, the blood supply of the humeral head to be cut off. So that becomes an urgent procedure. So generally, shoulder dislocations are managed by closed reduction, closed manipulated reduction, or CMR. Very rare situations where the closed manipulated reduction is unsuccessful, you have to resort to open reduction. One more thing I have to tell you, there is something known as a fracture dislocation. When you're talking about dislocation, you are not considering a fracture. But sometimes dislocations like the shoulder dislocations are associated with fractures. For example, the common fractures that you get along with the shoulder dislocation are greater tuberosity fracture, proximal humerus. So that is the importance of taking the proximal humerus fracture along with this topic. Proximal humerus. Sometimes you get fracture of the clavicle. Sometimes you get fracture of the ribs. So when you have a fracture associated with dislocation, you call it as a fracture dislocation. So the most common fracture that is associated with the fracture dislocation shoulder is the greater tuberosity fracture. Okay. So we have to see how we are going to reduce the fracture, the dislocation. There are various techniques. If you go through the literature, there are more than 10-15 techniques are there, and many people have their own version of doing this technique. but essentially the principle is the same. As undergraduate, there are 4 or 5 techniques which are historically important for your exams. So I will go through this step by step. Okay. Now, for any reduction to happen, you have to have the confidence of the patient. You have to make the patient as relaxed as possible. As relaxed as possible. Why? Because when there is a dislocation, the muscles are in a state of spasm. You have to relieve the spasm of the muscles. That is where your skill lies. You have to talk with the patient. You have to alleviate their fears. You have to ask them to cooperate. Of course, you can you put an IV line and give some sedation. And in some cases, you will have to resort to anesthesia. Take the help of the anesthetist also to anesthetize the patient. But generally, shoulder dislocation can be reduced even without anesthesia if you follow certain steps. Just there are 4 or 5 techniques that I have just mentioned. One is the traction counter traction method. Second is the Hippocrates method. Third is the Stimson's technique. 4 is a Coker's technique. Maybe 5th one is the Ferris method. All these are different techniques are there for reduction. Of this, Coker's has got a very important, very relevance in your practice, because that is the most common technique that you use generally. So I will go through each of the technique and I will tell you how each of this has to be done. Now, see, this is the traction counter traction method. This you have seen. If you are coming to casualty, you will have seen this traction counter traction method. So what is the use of traction counter traction? This is to relieve the muscle spasm. So it's assuming that this is an anterior dislocation. The surgeon stands on the side of the affected affected arm, and what he does is he gives a downward traction along the humerus by holding just above the elbow, and assistant gives a counter traction with a rolled towel under the axilla, and along with the traction, a mild external rotation is given to the affected limb. This external rotation, what is the reason for giving this external rotation? This external rotation will make the cartilaginous globular part of the humeral head to come out of the bony block there. So generally, this has to be this is painful if you are doing it fast. So you have to do it very gently. Talk with the patient, relax him as much relaxed as possible, and do the reduction. Once you reduce, now you will hear a clunking sound, which indicates the shoulder, the humeral head falling back into the ligament, and patient will have a sudden relief of pain. So that is how the traction counter traction is. So the positions I have told you, we can just see this figure now. So this is the traction counter traction. How that counter traction is given under the pillow using a rolled towel. Okay. Now this is a Hippocrates method. This is the age-old method where you use one leg of the surgeon, and the surgeon is actually giving the counter traction by himself and also pushing on the humeral head by using his feet, and the other limb is actually giving the traction. So the counter traction is given by the leg of the surgeon. The traction is given by the arm on, and there is light. You can see the arrows. There is internal external rotation generally, so that the humeral head is pushed into the socket. So one more diagram for the humeral head from the side to make you understand. So the traction by the examiner or by the surgeon. Counter traction is provided by the foot of the surgeon. Now, this is not another method known as Stimson's method. Now, Stimson's method is a passive reduction technique. Here the patient is kept prone, and you attach a weight onto the arm of the patient, with the arm dangling down the side of the examination couch. You keep it for some time like that. You raise the weight, and sometimes the shoulder will reduce. Generally, these are not used because it is difficult to keep the patient prone and all. But that is, you should know what is a Stimson technique, because Stimson technique is one prone technique of reduction in prone position. Then we'll come to what is the Cohort technique. Cohort technique. Now, this is the one that is commonly used by many of the surgeons. So the first diagram, how? See, position of the affected limb. The examiner is holding with his right hand. If it's on the right side, it's on the right by the right hand of the examiner, but by holding the elbow and giving a traction along the elbow. Then what happens? The arm is slightly abducted. The arm is slightly abducted, and the arm goes into gentle external rotation. Gentle without making painful. Gentle external rotation. And once you go into full external rotation, the arm is taken into adduction and then internal rotation. Arm is taken into adduction, and so first is the slight abduction, flexion of the elbow, traction. Then gentle external rotation. Once external rotation is achieved, you take the arm into adduction and internal rotation. These are the 4 steps in internal rotation. You can combine these techniques. If you want to give a counter traction, you can use a rolled towel under the axilla and ask your assistant to give a counter. Sometimes it may be needed in muscular injuries. So this technique, this is a Cohort technique. Okay. Then what are the complications? So what are the complications of anterior dislocation? You can have early complications, late complications. So as I already told you, early complications can injury to the axillary nerve. It can be injury to the axillary artery. Sometimes it can be associated with the injury to the surrounding bones, like I told you about the greater tuberosity, lesser tuberosity, neck of humerus. And very important, the thing that you missed is it can also cause an injury to the rotator cuff, particularly in old age individuals. Suppose the patient is coming after 50 or 60, along with the shoulder dislocation, you might have a rotator cuff tear as well, which will hamper the rehabilitation of the patient. Sometimes if the injury is very severe, you can have certain specific lesions which are known as Hill-Sachs lesion and Bankhart's lesion. What is Hill-Sachs lesion and Bankhart's? I will tell you. I will come in a minute. So we'll go to that. Okay. So this is the one that I was telling about earlier. So this is if there is an axillary nerve injury, you look at sensation here. You look for pinprick and touch. Pinprick and touch in this marked area. This is the area where you get a regiment's bad design. Now coming to Bankhart's lesion. What is a Bankhart's lesion? This asks us a short note, 2-mark question. So Bankhart's lesion, 2-mark question. So when the position in which the shoulder dislocates is this position, abduction, external rotation, abduction, external rotation. So what happens to the humeral head? There is a capsule. No, there is a shoulder aortic capsule, and when you dislocate, the humeral head comes out of the capsule, tearing the capsule. Where is the tear going to occur? Typically, the tear occurs in this portion. This portion, where is this anterior part and the inferior part. Anterior where the capsule and the labrum comes and joins. Where the capsule and the labrum of the glenoid comes and joins in the anterior and inferior part of the glenoid. That is the area where usually the capsule gets torn. That lesion is known as a Bankhart's lesion. So that you can see in this image as well, the anterior aspect and the inferior aspect. Because every time you take the shoulder into this position, into the abducted and external rotator position, you can feel your humeral head coming and stretching your capsule in this portion, the anterior inferior portion. So that is the anterior inferior lesion in the glenoid. That is known as the Bankhart's lesion. Bankhart's lesion. Okay. So if you are asked for a short note on Bankart, these are the 4 points that you should write. Capsulolabral avulsion. In the end, the site is important. Anterior inferior aspect of glenoid. It forms a hammock for the humeral head to rest. So every time you take that position into abduction external rotation, it becomes weaker and forms a hammock. this will result in recurrence of the dislocation of the shoulder, recurrent dislocation. And sometimes, since every time the humeral head will come and hitch against this portion, the glenoid, there can be a mirror change in the humeral head, which is seen in the posterior superior. Because you see, when you are keeping the arm by the side, this is the position of the humeral head. Now, when you are taking the external rotation, the posterior aspect of the humeral head actually comes anteriorly. So this posterior aspect of the humeral head will come anteriorly and hitch against the sharp bony area of the glenoid. So in the posterior superior aspect of the humerus, posterior superior aspect of the humerus, you get a depression in the humeral head, that is known as a Hill-Sachs lesion. So Hill-Sachs lesion is a mirror image of what occurs in the humerus, while the Bankhart's lesion occurs in the glenoid. So what is the treatment of Bankhart's lesion? You may have to do an open or arthroscopic Bankhart's. So these 4 or 5 points should be there when you are asked about Bankhart's lesion. Okay. So then Bankhart's lesion can be bony as well. We told about capsular ligamentous lesion. One more point that you can add is, depending upon the velocity in which dislocation occurs, suppose a violent dislocation, the bone itself can get fractured. That is known as a bony Bankart. You can see this X-ray, this CT scan. This is the bony Bankart, almost at the same side. At the anterior and inferior. This portion is anterior. This is posterior. So that is the bony Bankart. Now, to show the Hill-Sachs lesion, see, when you are taking the humeral head into humeral head abduction, external rotation, the glenoid portion here will strike against the humeral head. This is the anterior portion. This is the posterior portion. So it is the posterior superior. So Hill-Sachs lesion, same things you can write, but it is in the humeral head. It is the posterior superior aspect. Bankart is in the anterior inferior aspect. Hill-Sachs lesion the opposite, posterior superior aspect of the humeral head. This is also another cause of recurrence of dislocation. To make it little bit more clearer, the labral attachment, this anterior inferior aspect, diametrically opposite. You can see the posterolateral head defect, which is known as the Hill-Sachs lesion. So when you have a combination of Bankart's plus a Hill-Sachs, the chance of getting a recurrent dislocation of the shoulder is very high. Okay, that is the importance. We have discussed about the early complications, axillary, the neural injury, fractures, the Bankart's lesion, the Hill-Sachs lesion, rotator cuff injury. Now we come to the late complications. Late complications, most common that you get is a vascular necrosis of the head of humerus, because of when there is high risk, when there is delay in shoulder reduction, the shoulder, the humeral head can go into a vascular necrosis. Then sometimes you can get heterotopic, particularly if the patient is coming after is having a delayed presentation and has gone for massage, Ayurvedic massage or the local Vaidyan massage and all, they can get heterotopic calcification. Then recurrent dislocation, of course, is a late complication of every traumatic anti-dislocation. Okay. Now, one more thing, we have to, when you release the shoulder, you have to immobilize this shoulder for 3 weeks by keeping the limb adducted. This is to make the capsule heal. Okay. So that covers our main discussion today. Now I will go through posterior dislocation. I've told you posterior dislocation very rare, 5% of the dislocations. It is usually seen as seizures. It is sometimes seen in electrocution and all. Here I told you in shoulder dislocation, patient is coming with slight abduction, while in posterior dislocation, the patient is coming with shoulder in adduction, flexion, and internal rotation. The typical finding is the shoulder is locked in internal. There is no external rotation at all in a posterior dislocation. That is important. The shoulder is locked in internal rotation. Told you all this. So that is a posterior dislocation, and you see this is see this is the lateral view. This is known as scapular Y view. There are various traumatic views for trauma shoulder. See, you can see this is the coracoid. This is the coracoid, and you can see if the humeral head is lying anteriorly, it will be here. Here it is lying posteriorly. So a lateral view known as a scapular Y view will tell you whether the shoulder is an anterior or posterior. Close reduction of a posterior dislocation. not very important for you, but you have to give. So it is adducted like this. So the traction line has to be, the other one we are keeping in abduction and rotating. In a posterior dislocation, your traction has to be in the line of adducted, and somebody has to gently lift the humeral head into the glenoid fossa. Just 2 points in the line. So traction adduction, the other one in slight abduction. Now, what are the indications for operative treatment? Of course, if you are not able to do an open reduction, to do a closed reduction after giving anesthesia, also you're not able to do it. Then, along with the fracture dislocation, for example, you have proximal humerus fractures along with the dislocation. Most often, you will have to have an open reduction. Okay. These things in posterior dislocation, you get a reverse hillside. Not important for you, that you can omit, no problem. Okay, these are all the complications you can have. They can have complications of similar type. Okay, then we'll come to the inferior dislocation, which is not luxative recta. Now, the typical attitude when the patient comes to the casualty will be like this. Patient will keep the arm above the head. Above the head. Patient will not be able to come down because it is inferior dislocated, and the moment you try to bring it down, patient will have severe pain. Now, it is interesting to see how it is reduced. See, this will be the position. See, this will be the position. Arm will be abducted. See, and you can see the humeral head is lying inferior. The humeral head, the glenoid is here. The humeral head is lying inferiorly. So it is this is the attitude of the limb. Now here you see the traction has to go in the hyperabducted position. See, upwards, and the counter traction has to come from above downwards. So the towel is above the clavicle. The other one, the towel was at the below in the axilla. Okay, so that is the thing. Okay, not important for you. I will skip this. So in inferior dislocation, you have to remember that though it is rare, it has maximum complications, particularly the injury to the vascular and the neural structures. Okay, so that completes the discussion on shoulder dislocation. I'm not seeing any comments in the chat box, any doubts in the chat box. Please, if you have any doubts, we can spend 2 minutes here and clear those doubts. After that, I can go to the next. There is a small topic. I will have only few minutes of that. Hello. Hello. Hello.
Yes, sir.
Anybody has to ask anything, they can ask. We can spend 1 or 2 minutes. Is my next topic seen in the slide? Is seen in the screen?
No, sir.
What happened? All of you still there? Hello.
Yes, sir.
How many are still there? I think most have left. I think.
No, sir. We are here.
They are here. Nobody is responding anything in the chat box. How many of you have sustained anybody who has sustained a shoulder dislocation in his life? Just give a raise your hand. That use that icon. Okay. We will go ahead with the proximal humerus fractures. Okay.
Okay, sir. Okay.
Now, proximal humerus fractures, there are only 2-3 points that undergraduate has to remember. See, even when you tell as a proximal humerus, what are the structures that are involved in the proximal humerus? You are talking about greater tuberosity. You are talking about lesser tuberosity. you are talking about anatomical neck and the surgical neck of humerus. Okay, these are the structures that we are interested in. Why we are interested in this? Why we are taking this as a different topic from humerus? Because of the muscle attachment. You know, the graded tuberosity is important because the muscles of the rotator cuff. What are the muscles of the rotator cuff? The supraspinatus, infraspinatus, teres minor are the muscles that are attached onto the graded tuberosity. Subscapular is attached to the lesser tuberosity, and the deltoid muscle is attached below the proximal humerus, and the pectoralis minor muscle is attached to the intertubercular sulcus of the humerus on the medial side. So these are all, so the supraspinatus, infraspinatus, these are external rotators. Subscapular is an internal rotator. Deltoid is an abductor. The pectoralis are adductors and medial rotators. So all these are muscles are actually acting in a different directions. So fractures on one of these bony attachments can produce a lot of deforming forces. So that is why we are taking as the proximal humerus as a separate topic. One more thing that is important is the head of the humerus is supplied by the end arteries coming from anterior circumflex humeral artery. You know that the surgical neck of the humerus has got a arcade of vessels coming from anterior circumflex and the posterior circumflex humeral artery, which are all branches of the axillary artery. But once that ascends into the anterior circumflex ascends through the intertubular groove, they become end arteries to supply the humeral head. So vascular supply can get cut off in a fracture. So that is the importance of looking at the proximal humerus fracture. I will go through this very quickly. So these proximal humerus fractures are mostly seen in people who are osteoporotic. Usually seen in old age ladies. Old age ladies, they get these osteoporotic fractures. But in young adults, they get violent trauma. Okay. This is what I was talking about. The attachments here, graded tuberosity, the rotator cuff muscles are coming and attaching here. The subscapular is coming and attaching the lesser tuberosity. This is the surgical neck part. Then this is the anatomical neck part. Okay, and that anatomy should be clear. This was a blood supply I was talking about. See, the anterior branch of the anterior circumflex. This is the primary supply. Anterior branch of the anterior circumflex. This is the primary blood supply. They are coming from axillary artery with the limited supply only from the posterior circumflex. So this area is not very well vascularized. So this is one of the common sites in the body where you get avascular necrosis. Okay. This is the blood supply that I have already mentioned the important point there. Then, depending upon how displaced the fracture, the name of this classification, you know what is known as near classification. So I told you there are 4 parts. You call the proximal humerus divide the proximal humerus into 4 parts. One is the great tuberosity part, lesser tuberosity part, anatomical neck part, and the surgical neck part. Now, if there is a fracture in any of these, but the displacement is less than 1 centimeter or the angulation is less than 45 degree, you call this a 1-part fracture because everything is more like a mass of bone. When any of these fractures are displaced, what is the displacement? What does mean by displacement? When there is a displacement of more than 1 centimeter or angulation more than 45 degree, you call it as a 2-part, 3-part, or 4-part, depending on how many fragments are there. That is the basic idea of this classification. So you can see the 4-part means the humeral head. You can see the humeral head is dislocated here. Great tuberosity is lying here. The humeral head is here. This is the lesser tuberosity part. This is the great tuberosity part, and the shaft is separated. So so that is known as a 4-part displacement. Just to make you aware. Then see we can have one of the complications that you can have is a traumatic avascular necrosis, post-traumatic avascular necrosis. Treatment, non-operative, non-operative treatment is there, operative. Generally, if it is osteoporotic patients, old age patients, you generally opt for non-operative treatment. The problem with non-operative treatment is the abduction is limited after your treatment, because 30-40 degree, maybe 50 degrees abduction they will have, and they may usually have pain also. So in young patients, you will have to have or resort for, because this is not a good for conservative treatment, you will have to do either a osteosynthesis by doing an open reduction internal fixation, or sometimes you have to replace if the bone is avascular, the high chance avascular necrosis is there, you will have to replace that humeral head, which is known as a hemiarthroplasty. Okay. So you look at this, the non-operative usually poor results. The only 1 out of 1/16 will be able to raise their arm above 90 degrees, and most will have constant pain as well. Okay. Then the relevant portion I will come. To your see. So this is a 4-part fracture. So you can see that this is the greater tuberosity fragment actually is comminuted, lesser tuberous somewhere here, the humeral head is somewhere here, the shaft also there is a fracture. So all these are and even you can see that the it is not dislocated. It is not dislocated. So the surgeon here has opted for, see, this is a hemiarthroplasty. So you should remember the conservative treatment. Second thing is open reduction internal fixation, either with screws, K-wires, or by plate fixation. And in cases where there is high chance of avascular necrosis, you have the option of doing a replacement, hemiarthroplasty. I was just looking where the plate was in this figure here. This is the plate and screw. This plate is known as a Philos plate. You should know this. PHILOS. 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 That is known as proximal humeral internal locking system. It is a Philos plate. PHILOS. PHILOS. So I am just finishing off here. It's time now. So somebody can give a comment, and anybody wants to clarify any point? Hello? Hello?
Yes, sir.
Abdullah, if anybody wants to add anything, you can do. We can wait for 1 or 2 minutes. Afterward, you can conclude. And you share me the link as well. The link means the recorded. If it is recorded, I want to have the recorded, so that will be available in my website as well for students.
Okay, sir.
Okay.
Yes, sir.
If then you can conclude, Abdullah. If nobody is volunteering for a, because that is a problem with the online teaching. You cannot know how many have registered what I am telling. Did you register? Were you able to follow?
Yes, sir.
I kept it as simple as possible. Just to these are the questions that are going to be asked. There will not be other questions. These are the questions that are going to be asked. So you can conclude, Abdullah. Abdullah.
Yes, sir.
You can conclude. You can give a concluding statement and we can push off.
Okay. Thank you, sir, for having this class. So we can uh, leave, I think. In the next class, teachers have joined, I think, sir.
Okay. Okay.
Thank you, sir.
Okay.
Shall I start the class? ഹലോ നിങ്ങൾ 118 ബാച്ച് അല്ലേ ഇപ്പൊ ക്ലാസ്സിലിരിക്കുന്നത്?
യെസ് മാം.
ഓക്കെ, റെപ്പ് ആരാണ്?
മാം ഞാൻ അമൃത.
അമൃതയാണ്. ഓക്കെ, ഷാൽ വി സ്റ്റാർട്ട് ദ ക്ലാസ്?
ഓക്കെ മാം.
ഓക്കെ, ഷായത്തിനെ വിളിച്ച് പറഞ്ഞേക്കാം അവരെന്നെ പറയണം. Okay. Can you see the slides?
Yes ma'am.
Okay. So today we'll start cohort study. Last day you have studied case control, no? So today we'll start cohort study. So this is the plan of my presentation: introduction, features of cohort study, design of cohort, types of cohort, elements of cohort, advantage and disadvantage, the bias thing you need not study now, and summary and conclusion. Okay. So what is a cohort study? Basically, it's an analytical study. And the purpose of the study is to obtain evidence to support or refute the existence of association. The other names of study are prospective study, longitudinal study, incident study, or forward-looking study. So the prime purpose of this cohort, it's in hierarchy, it is a good study design. No? So our aim is to obtain evidence to support or refute the existence of association. And the other names are prospective study, longitudinal study, incident study. These are synonyms, or the forward-looking study. Okay. So what is the word meaning of cohort? Cohort, the word meaning is nothing but a group of people who share a common characteristics in a defined time period. For example, people who born in a particular year or a batch of particular year, your batch is a cohort. You share a common characteristic. Or those who marry in same year, that is a marriage cohort, or a same day, whatever it is. The thing is, they should share something common. So what is a cohort? It's a group of people who share a common characteristics in a defined time period. Okay. So these are the distinguishing features of cohort study. First is the cohorts are identified prior to the appearance of disease under investigation. That is the main point. We should identify the group or the cohort prior to the appearance of the disease. And then what happens? We observe over a period of time to determine the frequency of disease. We observe them, whether they are getting disease or not. Okay. And usually the study proceeds forward from cause to effect. Can you hear me?
Yes, ma'am.
Okay. So these are the distinguishing features. One is we identify the cohort prior to the appearance of disease under investigation. Then we observe them time to determine the frequency of disease. How many are getting disease? We have a group, we have an exposure, and we want to study the outcome of that exposure. So we are following them up and just see how many are getting the disease. Okay. Somebody, please unmute. And the study proceeds forward from cause to effect. That's the basic difference between a case control and
No, if I study a lover, എനിക്ക് തോന്നുന്നു കിട്ടുന്നില്ല.
ആരാണ് സംസാരിക്കുന്നത്? Please unmute.
അല്ല രണ്ടും വെച്ചിട്ട് ഞാൻ ഇത് ഉപയോഗിക്കുക.
ആരാണ് സംസാരിക്കുന്നത്?
ചുമ്മാ പറയാനല്ലേ, നോക്ക്. ഒരു സെക്കൻഡ്.
Excuse me, who is talking in between? So this is the design of, basically the design of a cohort study. First we have a population. At that time there was no disease, no? So first there is a population, we take sample from that population. Then we are moving forward in time. We identify one exposure thing, no? Something which is we are curious to know whether that exposure can result in disease or not. So we move forward in time. So we have one group who is exposed to a particular thing, and we have another group who is not exposed to that thing. And just we are observing them for a period of time. And what happens is, after a period of time, we just analyze how many of the exposed develop the disease, how many of the non-exposed develop the disease. Okay, then we compare the rates. That is what we do in this cohort study. And what we are looking for is the outcome. Okay. So these are the general concepts. So that is basically the design. First, we have a population. At that time, nobody has developed a disease. Then we take a sample from that population and we group it into two, that is exposed and non-exposed. Then we follow them for a long time, follow them for a particular period and see whether how they are developing the disease. If they are developing the disease, which group is having more chance to get disease, and the other group. Okay, so number of disease persons in each groups we identify, and then we calculate the risk. So that is the basic design of a cohort study. So these are the general consideration. Must be free from disease under study. Both groups should be equally susceptible. Both groups should be comparable. And the diagnostic and eligibility criteria to be defined beforehand. So what does it mean? Study design study start at that time they should be free from the disease under study. And both groups should be equally susceptible. നമുക്ക് വേറൊരു factor കൊണ്ട് അങ്ങനെ ഒരു disease ഉണ്ടാവാൻ പാടില്ല. Okay, so they should be susceptible. The susceptibility should be equal for that. രണ്ടുപേർക്കും equal chance ആയിരിക്കണം അസുഖം കിട്ടാനായിട്ട്. For example, നമ്മളിപ്പോൾ ഗ്രൂപ്പ്സിനെ തിരഞ്ഞെടുക്കുമ്പോൾ എന്താണ്, and both groups should be comparable to. ഇപ്പം ഒരു ക്യാൻസറിന്റെ സ്റ്റഡി നടത്തുകയാണ്, and we know that age is a factor. When age advances, the chance for cancer will also increase. So അപ്പൊ നമുക്ക് ഒരിക്കലും ഒരു മീൻസ് ലോവർ ഏജ് ഗ്രൂപ്പിനെയും ആൻഡ് ഹയർ ഏജ് ഗ്രൂപ്പിനെയും കൂടെ വെച്ച് രണ്ട് ഗ്രൂപ്പ് ആക്കാൻ പറ്റത്തില്ല. നമ്മുടെ രണ്ട് ഗ്രൂപ്പും ഷുഡ് ബി കമ്പയറബിൾ. ഓക്കെ, നമുക്ക് കമ്പയർ ചെയ്യാൻ മീൻസ് മാച്ച് ചെയ്യാൻ പറ്റുന്നിടത്തോളം നമ്മൾ കമ്പയർ ചെയ്യണം, മീൻസ് മാച്ച് ചെയ്യണം. ബിക്കോസ് അതൊരിക്കലും ഇത് എന്താണ്, ആ ഫാക്ടർ ഒരിക്കലും ഇതിന് ഡിസീസ് ഒക്കറൻസിന് റീസൺ ആവരുത്. മനസ്സിലായോ? So our group, both groups should be comparable and should be equally susceptible. രണ്ടുപേർക്കും ഒരേ ചാൻസ് ആയിരിക്കണം ഡിസീസ് കിട്ടാനുള്ളത്. ആ എക്സ്പോഷർ ഫാക്ടർ ഒഴിച്ച് ബാക്കി എല്ലാ കാര്യങ്ങളും they should be similar. Okay. And another thing is the diagnostic and eligibility criteria should be defined beforehand. നമ്മളിപ്പോൾ ഒരു ഡിസീസിനെ പറ്റിയാണ് പഠിക്കുന്നത്. സോ ആ ഒരു ഡിസീസിന്റെ ഡയഗ്നോസ്റ്റിക്, there should be some diagnostic criteria, അല്ലേ? So these are the signs and symptoms. And this is how we diagnose it. There is a particular lab diagnostic test for that, and we use that test for confirmation of disease like that. So we define the diagnostic and eligibility criteria before we start our study. So that's it. Okay. So and that is another important. നമുക്ക് ഇഷ്ടം പോലെ നമ്മുടെ സ്റ്റഡി തുടങ്ങി പിന്നെ നമ്മൾ ഡയഗ്നോസ്റ്റിക് ക്രൈറ്റീരിയ മാറ്റുന്നു, നമ്മുടെ എലിജിബിലിറ്റി ക്രൈറ്റീരിയ അങ്ങനെ പറ്റത്തില്ല. സോ നമ്മൾ സ്റ്റഡി സ്റ്റാർട്ട് ചെയ്യുന്നതിന് മുന്നേ എല്ലാം പക്ക പെർഫെക്റ്റ് ആയിരിക്കണം. ദിസ് ഇസ് അവർ ഡയഗ്നോസ്റ്റിക് ക്രൈറ്റീരിയ. ഈ ക്രൈറ്റീരിയ ഉള്ളവരെ മാത്രമേ നമ്മൾ ആ ഡിസീസ് ആണെന്ന് പറയത്തുള്ളൂ. ആൻഡ് എലിജിബിലിറ്റി ക്രൈറ്റീരിയ ഓൾസോ. നമുക്ക് ഇഷ്ടംപോലെ അങ്ങോട്ടും ഇങ്ങോട്ടും മാറ്റാൻ പറ്റത്തില്ല. സോ ഇറ്റ് ഷുഡ് ബി ഡിഫൈൻഡ് ബിഫോർ ഹാൻഡ്. ഓക്കെ. So these are the different types of cohort study. One is prospective cohort study. Second one is a retrospective cohort studies and combination of retrospective and prospective cohort studies. Okay. I'll tell one by one. First one is a prospective. Prospective means current study. Study. That is here. Data on disease outcome are not available at the onset of study. നമ്മൾ ആ സമയത്ത് നമുക്ക് ഔട്ട്കം വന്നിട്ടില്ല. ഓക്കെ. For example, Framingham heart study, Dole and Hill study on smoking and lung cancer. Framingham heart study നമ്മുടെ cardiovascular disease what all risk factors are there ഉള്ളതാണ്. അപ്പം what are the risk factors for cardiovascular disease? Usually dyslipidemia, hypertension, obesity. അപ്പം multiple risk factors are there. അപ്പം അത് വെച്ചിട്ടാണ്. അപ്പൊ ആ സമയത്ത് നമുക്ക് ഔട്ട്കം അറിഞ്ഞൂടാ, how many will develop or not. And also we are pretty sure about the association of this smoking and lung cancer. The study was this was a study. There is a Dole and Hill study on smoking and lung cancer. നമ്മൾ ഔട്ട്കം അറിയത്തില്ല, we just followed up. Okay. So this is another example. നമുക്കറിയാം ന്യൂ ബോൺ ഇൻഫൻസ് അല്ലെ. ന്യൂ ബോൺ ഇൻഫൻസില് നമ്മൾ 1989 ജനിച്ച കുട്ടികൾ. Direction of inquiries forward. And we have two groups, very low Apgar score and very high, a pretty good Apgar score. Okay. And we follow up them in for years, in 1990 till 2001. അപ്പൊ അതില് നമ്മൾ കണ്ട എന്താണ് what we found was low Apgar scoreൽ കുറച്ച് പേര് ഡിസേബിൾഡ് ആയിട്ടുണ്ട്, higher Apgar scoreലും കുറച്ച് പേര് ഡിസേബിൾഡ് ആയിട്ടുണ്ട്. Our finding is the children with the number of children who are disabled is more in very low Apgar score group than those with, you can see the circle, no? It is more in number. The disabled ones are more with the very low Apgar score group. And in higher Apgar score group, the number is very less. Okay, so it's an example of, so we start our design in 1989 and we followed up through years till 2001. Okay, that is prospective. And these are the strength and weakness of post-prospective study. That is, one is temporal relationship is established. Multiple outcomes can be studied. Good for studying. Outcome. And weakness is loss of follow-up for longer. നമ്മളിപ്പോൾ cohort study ആകുമ്പോൾ usually we need to follow up them for a long time, no? So sometimes the study participants may drop the study, and also it's expensive. നമുക്ക് follow up ചെയ്യണമെങ്കിൽ it's quite എന്താണ്. Can you hear me?
Yes, ma'am.
Okay, weakness is loss to follow up. നമുക്ക് കുറച്ച് ഗ്രൂപ്പിനെ കുറെ നാൾ follow up ചെയ്യാൻ it's very difficult. So there is chance for loss to follow up for longer duration, and also it is expensive. Okay. Next is types of cohort study. No, sorry. Prospective. Next is the retrospective cohort study. Retrospective cohort study. I'll tell you what happened on the screen. The outcome have occurred before the start, and the investigator goes back in time to select his study groups from the existing records. Okay. And traces them forward through time up to the present. അങ്ങനെയാണ് retrospective ചെയ്യുന്നത്. The investigator goes back in time, select his study groups from existing records. And traces them forward through time up to the present. It's otherwise known as historical cohort. It is usually retrospective direction. Okay. It's actually prospective, but in prospective direction. So next is, just wait some more. You just wait. Okay. Prospective. Okay. Can you hear me?
Yes, ma'am.
Okay. ആരാണ് അതിനിടയ്ക്ക് പടമൊക്കെ വരച്ചിട്ടത്? Can you see the screen now?
Yes, ma'am.
Okay. Next is the combination of retrospective and prospective study. Okay. So here we combine both the elements, that is retrospective as well as prospective elements. And the cohort is identified from past records and is assessed of date for the outcome. The same cohort is followed up prospectively to future for further assessment of outcome. Hence, example is to study the effect of radiation therapy on ankylosing spondylitis. Okay. But what we usually do here is they assembled a cohort in 1955 consisting of 13,350 patients, 352 patients who had received large doses of radiation therapy for ankylosing spondylitis between 34 and 54. ആ സമയത്ത് എത്ര പേർക്ക് കിട്ടിയിട്ടുണ്ടെന്ന് means high dose of radiation. And the outcome they measured is leukemia or aplastic anemia that occurred between 1934 and 1954. Okay, നമുക്കറിയാം radiation therapy ഉണ്ട്. Sometimes they develop aplastic anemia or this leukemia. അപ്പോൾ അത് എത്ര പേർക്ക് വന്നെന്ന് അനലൈസ് ചെയ്തു. And they found that the death rate from leukemia or aplastic anemia was substantially higher in the cohort than that of the general population. അപ്പോൾ ആ റേഡിയേഷൻ തെറാപ്പി കിട്ടിയ ആൾക്കാരുടെ ഇടയിൽ this leukemia അല്ലെങ്കിൽ aplastic anemia was found in higher number. And again, in 1955, and they have followed up further. കുറച്ചുകൂടെ നമ്മൾ ഫോളോ അപ്പ് ചെയ്യും how many are more getting the disease. അതും കൂടെ നോക്കാം. So we combine both the retrospective as well as the prospective elements in the antispective study. Okay. So that's it. So this is in nutshell. Concurrent means forward. Non-concurrent from the records we take how many are exposed or not. Ambi means in both direction. Okay. Next we move on to the steps. E cohort study, case control study exam means theory they will ask for the scenario there. You have to write what is the type of study design and what are the steps of the study design and how will you analyze the data. Any questions? Okay. So these are the elements of study design, means cohort study. First is the selection of study subjects. Next is the obtaining data on exposure. Third thing is the selection of comparison group. Fourth thing is follow-up, and finally the analysis thing. Okay, one is selection of study subjects. Second is obtaining data on exposure. Third is selection of comparison group. Fourth is follow-up, and finally the analysis. And coming to the selection of study subjects, it should be either from general population or from select groups. In general population, when the exposure or cause of death is fairly frequent in the population. Sadhana common population cases exposure we can take from general population. Okay. The special groups exposure to general population a particular group of you will select from the we will take the samples from the special groups. Either it can be select groups, example any functional groups like doctors, nurses, lawyers, teachers, like that, or volunteers, or maybe the government employees. Dolls studying smoking and lung cancer. That's British doctors. Okay. Usually smoking we registered first details study group then we followed up. Okay, doctors and we followed up and from the mortality registers and all we analyzed the data. Okay. And next is the exposure group. Exposure means exposure population and more okay, more economical we can do in exposure group. Okay. For example, if you study the effect of radiation among radiologists, our group we select. Okay. So that's it. This is how we select the study subjects, either from general population or from select groups. or from special groups, either be select groups or exposure groups. Next is obtaining data on exposure. നമുക്ക് എങ്ങനെ നമുക്ക് full time അവിടെ പറയുന്നത് നിൽക്കാൻ പറ്റും, മീൻസ് ദിവസം പോയി പേഴ്സണൽ കാണാനോ അല്ലെ, മീൻസ് നമുക്ക് അങ്ങനെ എല്ലായിടത്തും ഒരുപോലെ എത്താൻ പറ്റില്ല. സോ എങ്ങനെ ചെയ്യാൻ പറ്റും? ഹൗ ക്യാൻ വി ഡു ദാറ്റ്? ഓക്കെ, നമുക്കിപ്പോൾ ഒരു ദിവസം മീൻസ് ഡാറ്റ കളക്ഷൻ അല്ല, വി ആർ ഫോളോയിങ് ഫോർ ദ പീരീഡ് ഓഫ് ടൈം. സോ ഹൗ ക്യാൻ യു ഡു ദാറ്റ്? ബൈ പേഴ്സണൽ ഇന്റർവ്യൂസ് ഓർ ടെസ്റ്റ് ലേയേഴ്സ്. നമുക്ക് അവരുടെ ഫോൺ ചെയ്യാം, അല്ലെങ്കിൽ മെയിൽ ചെയ്യാം, അവർക്ക് ഇഷ്ടമുള്ളപ്പോൾ അവർക്ക് മറുപടി അയക്കാം. ഓക്കെ, ആൻഡ് നെക്സ്റ്റ് ഇസ് ബൈ റിവ്യൂ ഓഫ് റെക്കോർഡ്സ്. ഓക്കെ, അപ്പം ചിലതിന് അവർക്കിപ്പം മേ നോട്ട് ബി നോൺ. ഫോർ എക്സാമ്പിൾ, ഇപ്പോൾ ഒരു സർജിക്കൽ പ്രൊസീജിയർ ആണ്, അപ്പം അതിന്റെ ഡീറ്റെയിൽസ് ഒക്കെ അവർക്ക് അറിയണമെന്ന് നിർബന്ധമില്ല. ആൻഡ് ഓൾസോ ദി ഹെമറ്റോളജിക്കൽ തിങ് ഓർ ദി ബ്ലഡ് റിസൾട്ട്സിനെ പറ്റിയിട്ടാണ്. അപ്പം സോ ദേ മേ നോട്ട് ബി അവർക്ക് അറിയണമെന്ന് നിർബന്ധമില്ല. ഓക്കെ, സോ നമ്മളപ്പം ഹൗ യു കളക്ട് ഡേറ്റ ബൈ റിവ്യൂ ഓഫ് റെക്കോർഡ്സ്. ഹോസ്പിറ്റൽ റെക്കോർഡ്സ് ഉണ്ടാവും, സോ വി കളക്ട് ഡേറ്റ ഫ്രം ദി റിവ്യൂ ഓഫ് റെക്കോർഡ്സ്. And next is by the medical examination or special test. So നമ്മുടെ സ്റ്റഡി സബ്ജക്ട്സ് ഉണ്ട്, അവരെ നമുക്ക് ഇപ്പം ഞാൻ നേരത്തെ പറഞ്ഞില്ല ഫാമിംഗ് ആൻഡ് ഹാർട്ട് സ്റ്റഡി. സോ നമുക്ക് അവിടെ ബ്ലഡ് കൊളസ്ട്രോൾ വാല്യൂസ് ഒക്കെ അറിയണം. So we can do that. That is blood cholesterol levels, as well as we can take ECG also. But that is one method of collecting data, is medical examination or by conducting special test. And anybody from the Chavara or Karnataka area in your batch? ആരെങ്കിലും ഉണ്ടോ ഈ ഗ്രൂപ്പില്? എല്ലാരും ഉറക്കമാണോ? ആരെങ്കിലും ഉണ്ടോ ചവറ കരുനാഗപ്പള്ളി ഏരിയ ഈ ബാച്ചില്? ഹലോ, ആരെല്ലാം ഉണ്ടോ? ആരും ഇല്ല? ഫ്രം കൊല്ലം? എനിബഡി ഫ്രം കൊല്ലം?
Yes, ma'am. കൊല്ലം.
ഓക്കെ, കൊല്ലം ഉണ്ട്. അപ്പൊ നിങ്ങൾ കേട്ടിട്ടുണ്ടോ ചവറ കരുനാഗപ്പള്ളി ഏരിയയിൽ റേഡിയേഷൻ എക്സ്പോഷർ ഉണ്ട്, ക്യാൻസർ കേസസ് ആർ മോർ എന്ന്? ഉണ്ടോ? കേട്ടിട്ടുണ്ടോ? ഇല്ലേ?
കേട്ടിട്ടുണ്ട്.
So that is something known as environment survey. Okay, information on exposure levels of suspected factor in the environment where the cohort lived or worked. അവിടെ വർക്ക് ചെയ്യുന്ന അല്ലെങ്കിൽ അവിടെ താമസിക്കുന്ന ആൾക്കാരുടെ ഡീറ്റെയിൽസ് we can collect. So that's another method. So how will we obtain the data? One is from personal interviews and questionnaires. Second is by review of records. Third is by medical examination or special test. And fourth one is by environmental surveys. Okay. So next is the selection of comparison groups. We can do internal comparison because നമുക്ക് അവരുടെ ഉള്ളിൽ മീൻസ് അവരുടെ ഇടയ്ക്ക് തന്നെയുള്ള കാര്യങ്ങൾ മീൻസ് ആ ഗ്രൂപ്പിന്റെ ഇടയിൽ തന്നെ we can obtain information degree of exposure available if it is only one cohort is involved, and we can classify and internal comparison can be done. For example, our different varying degrees of the smoke exposure, blood pressure, serum cholesterol level. Our individuals in a difference. So, a kind of compare by internal comparison. And next is the external comparison. For example, smokers and non-smokers. The smoker information on a degree of exposure is not available. We can take more than one cohort in the study group. For example, cohort of radiologists compared with ophthalmologists and entirely different group one. Okay, so we can do external comparison. And next, we can compare with the general population rate. Available for example, uranium minus. Uranium minus, the chance for lung cancer is more. Okay. Now, follow up how many developing lung cancer among the uranium minors. We can compare it with number of people developing lung cancer in general population. What did we get? We found that the cancer rates are more among uranium minors. Okay. So that is comparison with the general population. So what is our inference? They are more prone for cancer because of the uranium exposure. And next is the follow-up. Okay. So how can you follow periodic medical examination of each member? Follow-up means maybe for 1 or 2 years or more, maybe more than 1 year or so. So we have to examine the persons. Okay, disease. And also we can do by reviewing physician and hospital records. Hospitals like they will definitely go to hospital. So we can review the records of physician as well as hospital. And also we can do surveillance of death records. Death data is a very important document. No? In that we record the cause of death, any comorbidities like that. So routine surveillance of death records also we can do follow-up. And also by mail questionnaires, telephone calls, periodic home visits. We can do periodic home visits. Okay. And in the cohort study, here periodic medical examination yields the greatest information. Okay. So next is the analysis. Next, follow-up, we are analyzing the data. Okay. So we calculated it from the incidence rate. Cohort study, so number of new cases we are getting. Number of new people developing the number of people developing disease newly. That is the incidence rate. So we calculate the incidence rate of outcome. Outcome is the disease or death. Outcome among exposed and non-exposed. And we calculate the risk in terms of relative risk and attributable risk. Okay. So we followed up and we get this much of numbers are developing the disease. And so we calculate. So what is the inference we get from this cohort study? We get the relative risk. So here you can see 2 groups: cigarette smoking, yes, no. Number of persons developing the disease who smoke is 70. Number of disease number of people who develop disease among non-smokers is 3. So incidence among the smokers is 70 per 7,000, and incidence rate among non-smokers, that is 3 out of 3,000. So you can from here it's clearly evident. So the incidence is more among smokers. Okay. So relative risk is the incidence we get from the formula: incidence of disease among exposed divided by incidence of disease among non-exposed. It's a direct measure of strength of association between suspected cause and effect. RR is equal to 1 means relative risk is equal. What do you infer? Indicates no association. But association milla. It is more than 1 suggests positive association. Less than 1 suggests negative association. Okay. So how this is how you infer. For R is equal to 1, no association. More than 1 suggests positive association. Less than 1 suggests negative association. So this is the formula: incidence of disease among exposed by the incidence of disease among non-exposed. So we a problem the formula incidence among exposed is 10, incidence among non-exposed is 1,000. So RR is calculated as 10. That means the incidence rate of disease is 10 times higher in exposed compared to non-exposed. So cigarette smoking is a risk factor for smoke. That's our inference. Okay. So because the incidence rate of disease is 10 times higher in exposed compared to non-exposed, we infer that definitely the cigarette smoking is a risk factor for smoke. Okay. Next is attributable risk. Okay. So it is nothing but it indicates to what extent the disease under study can be attributed to the exposure. Here we can say we say it in another word like 90% of lung cancer. This is how we calculate the attributable risk. Incidence of disease among exposed by incidence of disease among non-exposed divided by incidence of disease among exposed whole into 100. We get it as 90%. It indicates that 90% of lung cancer among the smokers was due to their smoking. So that is how we define the attributable risk. Or in other words, what extent of disease under study can be attributed to the exposure. Next is population attributable risk. So the concept of population attributable risk is how much the amount by which the disease could be reduced in that population if that factor, factor is not there. Okay. In another, no, I will tell the formula first. Sorry. The incidence of disease in the total population minus incidence of disease among those not exposed to the suspected cause factor. This is the formula. Incidence in total population minus incidence in non-exposed group is divided by incidence in total population into 100. You'll get problems when you come for blog posting. So this is the formula for population attributable risk. It provides an estimate of amount by which the disease could be reduced in that population if the suspected factor was eliminated or avoided. A factor avoid that is the population attributable risk. As 86% of deaths from lung cancer could be avoided if the risk factor of cigarette were eliminated. Now we move on to the advantages. It is scientifically a much more stronger design. We can calculate the incidence. Incidence is the number of new cases. We can capture the new cases because we are following them. Okay. So definitely we can capture how many are getting the disease. We follow up follow up we can calculate. That is the incidence. Okay. And also several outcomes related to the exposure can be studied in slide. For example, or exposure and multiple issues that also we can study. But that also we can study. Several outcomes can be studied. Okay. And it provides a direct estimate of related. Calculation is pretty clear. We will get a direct estimate of the relative risk. And also dose response ratio can be calculated. Cigarette smoke cigarette 5 cigarette risk that also can be calculated. Okay. So these are the advantages. Scientifically much stronger design. Incidence can be calculated. Several outcomes related to exposure can be studied. Provide a direct estimate of relative risk. Dose response ratio can be calculated. And some disadvantages are also there. Cohort study involves larger number of people. We have to take a larger sample size. Take long time to complete the study. And also some administrative problems are there. Loss of experienced staff, loss of funding. Extensive record keeping. So you have to keep records also. Loss of a substantial proportion of original cohort. Drop out of issues cohort study. Okay. And study it's for a long period. No? So changes in standard methods or diagnostic criteria of the disease. And the diagnostic criteria means with the advancement of science, it will change always. Okay. So there will be changes in standard methods or diagnostic criteria of the disease. And the cohort studies are expensive too. Involved in the study, and so it is pretty expensive, and time duration also high, so expensive. And the study itself may alter the people's behavior. What does it mean? നമ്മൾ സ്മോക്കിങ്ങിൽ ലങ് ക്യാൻസറോട് പഠിക്കാൻ തീരുമാനിച്ചു. അപ്പം നമ്മൾ അസൈൻ ചെയ്തു സ്മോക്കേഴ്സിനെയും നോൺ സ്മോക്കേഴ്സിനെയും ഒക്കെ അസൈൻ ചെയ്തു. അപ്പം നമ്മൾ പഠിക്കുന്നുണ്ടെന്ന് പറഞ്ഞാൽ ദേ മേ ഓൾട്ടർ ദെയർ ബിഹേവിയർ. ഓക്കെ, അപ്പം നമ്മുടെ സ്റ്റഡി ഗ്രൂപ്പിൽ നമ്പർ ഡിഫർ. ഓക്കെ, ആൻഡ് ഓൾസോ എത്തിക്കൽ പ്രോബ്ലം ഓഫ് വെരിങ് ഇമ്പോർട്ടൻസ്. ബിക്കോസ് എന്തെങ്കിലും ഒരു പ്രശ്നം ഉള്ളതായിട്ട് നമുക്ക് തോന്നിയാൽ എത്തിക്കൽ ഇഷ്യൂസും ഉണ്ട്, നമ്മൾ അറിഞ്ഞിരുന്നിട്ട് നമ്മൾ പറഞ്ഞിട്ടില്ല എന്നുള്ളത്. ഓക്കെ, സോ എത്തിക്കൽ പ്രോബ്ലം ഓൾസോ ഇസ് ദെയർ. So these are the disadvantages of cohort study. Bias നിങ്ങൾ നേരത്തെ പഠിച്ചിട്ടുണ്ടാകും. Let it be there. So I will summarize. It's a type of analytical study. It starts from cause to effect, and the different types of cohort study, design and elements serves to calculate incidence, relative risk, and this population attributable risk. It measures the strength of association. So that's for today. Master, please contact me. I will share the Google form for your attendance.
Ma'am, chat box litta madi.
അല്ല, ഞാൻ വേറെ ലാപ്പിലാണ് അതുള്ളത്. ഒരു മിനിറ്റ്, ഞാൻ റഫിന്റെ നമ്പർ അറിയാമോ?
Ma'am, എന്റെ നമ്പർ 8392.
ഒരു മിനിറ്റ്. പറഞ്ഞോളൂ.
8392.
83.
Yes, ma'am. 8392 99
99
19
19.
09.
ഞാൻ ഒരു ക്ലാസ് എടുത്തിട്ടുണ്ടായിരുന്നെന്ന് തോന്നുന്നു അല്ലേ, ലാസ്റ്റ് ടൈം. ഓക്കെ, 8392991909 അല്ലേ?
Yes, ma'am. അതെ.
മെസ്സേജ് ഒന്ന് അയച്ചു തരാം. അല്ല, ഓക്കെ, ഞാൻ മെസ്സേജ് അയച്ചോ. സോ യു ഹാവ് ടു സബ്മിറ്റ് ഇറ്റ് ബൈ 12 o'clock. ഓക്കെ, 5 minutes തരാം, ഇപ്പൊ തന്നെ അയച്ചു തരാം. ഓക്കെ, ഐ വിൽ ഷെയർ ഇൻ യുവർ വാട്സ്ആപ്പ്. താങ്ക് യു.
Ma'am.
Wait. ലിങ്ക് ഷെയർ ചെയ്തിട്ടുണ്ട്. 11:05 ആകുമ്പോഴത്തേക്കും ഞാൻ ഓഫ് ചെയ്യും. ഓക്കെ.